Thank you, Dominic. Just a little change in the title, Towards Image-Guided Radiation Therapy, Precision Delivery and Informatics Support. I'm presenting on behalf of the leadership of the radiation program. Shown on the left is a medical linear accelerator capable of producing high-energy electrons and X-rays. The main objective with radiation therapy is to deliver a lethal dose to a defined target volume and at the same time spare surrounding healthy tissue. And most departments that are offering radiation therapy are pursuing something that's referred to as image-guided radiation therapy, and the ingredients are from top to bottom. You need to have good diagnostic imaging. There are a number of modalities that can help in terms of defining the target volume. And afterwards, you have to do volumetric contouring. So superimposed on the digital image, you have to have contour information showing where the target is and where the organs are that you want to avoid. Currently, most contemporary programs are using intensity modulated radiation therapy. This is defined as inverse planned radiation therapy, such that you start with a dose objective function, define the constraints as part of that, and then optimize the dose objective function, producing fluence maps for each of the directional ports that you want to deliver the radiation through. The IMRT delivery is made capable by a precision collimating device defined as a multi-leaf collimator. And then finally, as part of the treatment, you want to verify through another type of imaging that in fact you've delivered the radiation as it was planned or intended. And the last dot, which is probably the most important as far as this presentation, is that physicists and engineers and applied mathematicians and others that are involved with the precision delivery aspects tend to forget about the huge amount of information that has to be processed as part of determining whether this technology is effective in terms of producing good clinical outcomes. So shown here is where technology, the imaging, verification imaging technology has been. On the left-hand side is a diagnostic quality image. On the right-hand side is a megavoltage generated image, which is of lower resolution. And the idea is basically to compare those two on a port-for-port basis to determine whether or not you have delivered the radiation as planned. We have, as part of the treatment for prostate patients, implemented a step whereby inert seeds are implanted into the prostate at time of biopsy. And in fact, those seeds allow us to determine when we're delivering with the high megavoltage imaging where exactly the prostate is during treatment. And so we've implemented that ourselves locally. Getting back to the informatics problem, what was initially a standard called DICOM-3 as part of a PACT system for storing images basically and different modalities and other information as well for the patient has evolved to something called DICOM-RT. And unfortunately, there are no commercial products available that have the DICOM-RT implementation. So that's something we want to work towards, and we want to work towards it hard. And that's something that certainly our center needs support, hopefully from the University of Waterloo in pursuing that. So our IGRT agenda over the next little while, we want to complete our implementation of IMRT. That's the planning and delivery part of it. We have been funded for new technology called onboard imaging, and in a nutshell, it's basically diagnostic X-rays attached to your treatment unit, allowing you to do cone beam imaging, large field CT imaging, and pulse digital fluoroscopy. We are also hopeful that we will be able to pursue resources to get CyberKnife, and this is robotic technology that would involve precise control of the LINAC as well. And there is a big opportunity for informatics development. Hopefully CFI Hospital Research Fund might be an avenue for that, but if that doesn't work out, I just want to state that even locally we should be able to pursue this. So thank you very much.
Thank you, Rob. Just a quick question is, what's involved in moving to DICOM-RT? What type of work is involved?
There has been a non-commercial effort to establish what I would call the baseline ingredients of DICOM RT data storage. The Advanced Technology Consortium, which is an American organization that was founded a few years ago through NCI, established a baseline for the newer technologies it's basically a clinical trials organization that was set up to take data from institutions that would want to participate in some of the newer technology, the IGRT trials, or IGRT-based trials. And they have been successful in establishing, which I would say is sort of a floating standard, a current standard, and institutions that are participating in these trials have to conform to data submission standards per this organization. So that's really the basis of taking this forward. But there's a number of different objects associated with the image. So in fact, there's structure sets and dose information and treatment information and other objects that are part of that standard.
Jeff?
Hi, Rob. I don't know if you remember me.
I do, Jeff.
What frequency this kilovolt onboard imager, what sort of frequency, how many images per minute? What are you talking about?
Basically, you'd want to, it's different from conventional diagnostic CT where you basically image through around 360 degrees. So this would be every 5 degrees, and it would take probably 5 or 6 minutes as opposed to a few seconds to get the information for diagnostic CT. So it's basically, it's not diagnostic quality, it's lower resolution, but it's much better than megavoltage resolution as far as the verification.
Mostly for setup and not real-time motion tracking? Is that,
Exactly right. So if you were going to use this, you basically do your cone beam CT before treatment, and you would see whether, for example, the prostate had shifted. You would move your couch or move the patient in order to recenter the target and then continue with the radiation. But you would need pulsed digital fluoroscopy, which would be through a single port. So if the patient was breathing, for example, you'd be watching basically lung motion, and you would, in fact, would be pulsing your radiation to suit a particular point in the breathing cycle, for example.
Just a quick question. Is DICOM RT group or work group within DICOM, or is it completely different?
It is. There is a working group 7 as part of the DICOM standard that have been working on it for the better part of 10 years, actually, and it's evolving as a standard, as an imaging standard. So yes, it's a formally defined entity.
And are you working with IG, integrating that kind of device?
Who are we working with? We're actually, right now, the Cancer Care Ontario is trying to pursue commercially this product. So in fact, we worked through...
IG is non-commercial. It's purely radiation oncology has joined IG last year, so it's a pure initiative, interoperability of initiatives to make things work together.
Right.
So it's just that beyond.
I'm sorry, I maybe didn't. So you're talking, the IHE-RO, which is, I'm sorry, I didn't get it. They're actually above HL7 and DICOM, so I'm with you. And in fact, we're trying to get the commercial vendors to basically work together to solve this, because it's not just an imaging problem. All of the vendors basically that have equipment have to comply with that standard in order for everything to talk to each other.
Other questions or comments? I also want to add, Rob is an adjunct, I believe, in the Department of Physics and Faculty of Science, and has been our key contact liaison with Grand River Hospital related to this kind of work. So for that and your presentation, thank you very much.